Hi everyone, it's Anjanette and I am here to do your Neurocognitive Disorders lecture. This is chapter 14 in our current textbook. So neurocognitive disorders really are related to neural decline. So our cognitive functioning declines, and sometimes there's a medical condition involved that might explain or correspond with that decline. Sometimes there's associated diseases. Sometimes we don't know the explanation. And so there's three main categories for this diagnosis. There's delirium, which we'll talk about the characteristics of, major neurocognitive disorders, and mild neurocognitive disorders. Now, there's specific disorders within those three main categories, except for delirium, and we'll talk about those. Typically, neurocognitive disorders are degenerative in nature, especially as it relates to the mild and major neurocognitive disorders, not necessarily the delirium. The delirium they can actually recover from. The other neurocognitive disorders are degenerative in nature, meaning they progressively worsen over time. So we expect symptoms to worsen. When we do diagnoses for neurocognitive disorders, we typically are looking for functioning across 6 main cognitive domains, many of which are attention focused and attention related, right? So can they sustain attention or pay attention for longer periods of time? What are their skills or functioning in divided attention or multitasking, doing more things at once? And can they selectively attend? So when there's other distractors or stimulation in the room, can they focus their attention on a specific thing? And can they process information in what would be considered an expected time frame or a normative time frame? Executive functioning relates to kind of higher level thinking, planning, decision making, problem solving, changing habits, being able to mentally adjust and adapt, and then also taking correction, responding to feedback, adapting as needed, whether it's your mindset or what you're doing. Learning and memory, so being able to tune in to recall recognition for memory tasks, having access to retrieval, right? Being able to pick up on retrieval cues. And then also our long-term memory often is associated with impairment in neurocognitive domains. And then learning might be challenged as well, particularly implicit learning. And that also speaks to some of our implicit memory as well. And so those two things kind of go hand in hand and decline together. Language skills, particularly as it relates to expressing emotion, thoughts, and then also receptive language. So being able to process that conversation from others and with others. And then perceptual motor skills also can be impacted, and that might be related to visual perception. Here's an error. I don't exactly know what I meant by that. Perceptual and motor, stability, and then visual construction. And then social cognition is also an area where we need to be able to engage in kind of emotional intelligence, recognize emotions of others, understand that others have different perspectives as it relates to theory of mind. And so being able to have a multifaceted, complex conversation, understanding it's an exchange of differing perspectives. So for those of you that might respond better to visual graphics, here is a visual graphic explaining those 6 different cognitive domains that are integrated into our diagnoses of neurocognitive disorder. And then let's go in and talk about the first, which is delirium. When we're talking about delirium, when we say someone's delirious, right, it means that they're not fully cognitively engaging, and so their awareness and their performance may suffer as a result. So that's typically manifested in non-normative behavior. They definitely will have challenges focusing their attention, paying attention for long durations. They may become fixated on something, unable to shift their attention. And their cognitive ability, they're not themselves. This actually might resemble kind of a psychotic break, where they might actually experience hallucinations and engage in incoherent speech, similar to some of the schizophrenia symptoms that we discussed in the other module. Often this might come on suddenly. It can last for hours. An episode can actually last for days or even months, but they can actually recover from delirium. And so they can recover with or without treatment in some cases as well. Major neurocognitive disorders are typically what we think of when we think of declining neurocognitive ability. Now, we used to talk about them all just like as dementia, a whole classification of dementia. But dementia is, in fact, one type of neurocognitive disorder, but we no longer reference these disorders as being in kind of a dementia umbrella. But with major neurocognitive disorders, they really do have major disruptions to their cognitive functioning, and they lose their ability to live independently. They may not be safe taking care of themselves. They may wander off, forget who they are. They may have errors and accidents in the kitchen that can put them at risk and in danger. So independent living is definitely compromised. So when you talk about the activities of daily living and just being able to care for themselves, engage in self-care, manage their households, taking their medications reliably, even making sure they're eating on a regular basis, all of those things can be compromised. And so as such, they often need a caregiver, whether it's a family member or a professional caregiver, and they are the ones that recognize the declining symptoms. So they are often working with the medical professionals to provide the history of the symptoms and the progression. Now, it is helpful, part of one of the diagnostic tools is to do a neurocognitive assessment, and that might be with the caregiver present as well. And that might be a good emotional support for them as well, because this can be scary. And it is important to note that dementia does fall into this category. Now, to some extent, dementia can be a natural part of the aging process, but certainly when there's some sort of injury involved or some sort of illness, we wouldn't necessarily diagnose them with dementia. That would be associated with whatever respective illness or maybe a traumatic brain injury that might constitute the neural cognitive deficits, but not necessarily be caused by a neurocognitive disorder, if that makes sense. Mild neurocognitive disorder differs from major cognitive disorder in that they might have a modest decline in cognitive functioning, but they can still manage to take care of themselves and maintain their activities of daily living. They might need help here and there, but overall, they're still very functional, right? So that difference in severity and that difference in how well they're able to engage in that independent living really marks the difference between mild and major neurocognitive disorders, but they might experience similar symptoms just on a very mild scale. Now, it actually could be the same disease, right? And mild neurocognitive disorder might just be in the early stages of those diseases, of the disease, and then major could be later rather than looking at them as two separate degrees, it could just be a spectrum of the progression of one single disease. So when we look at frequency rates or prevalency rates, delirium can occur in a good chunk of people who might be in the hospital for other reasons, for another medical cause, particularly for our elderly populations. But overall, it only affects about 1 to 2% of the general population, but people over 85, about 14% of the population. Delirium often becomes a symptom of some basic health conditions for elderly individuals. Something like a bladder infection can cause delirium in an elderly individual, but not likely to do that in a younger individual. When you're talking about major neurocognitive disorder or mild neurocognitive disorder, dementia, Alzheimer's, and traumatic brain injury fall within those larger categories. And dementia has just a 1 to 2% for 65-year-olds, but notice it progressively gets worse, 30% at 85, and 60 to 90% of those cases are due to Alzheimer's. So Alzheimer's can be categorized as a type of dementia, but it's unique in that it has specific characteristics of the brain that you don't necessarily, even though the symptoms and expression of the disease might be similar to other dementias, it has a very distinctive pattern of brain structural issues, and we'll talk about that when we get there. Alzheimer's is actually a little bit more common when you're talking about younger late adulthood, right? Early late adulthood. But when you're talking about middle and older late adulthood, it has significantly higher rates. So with both dementia and Alzheimer's, your risk of getting those increases significantly with age, most so at 75 and older. Only a smaller percentage of the population have them below the age of 75. Traumatic brain injury coincides with some sort of external brain trauma, and then what it does is it damages the brain and it causes neural and cognitive deficits and poor functioning overall. It does affect males more so than females. That could be the nature of the activities that put you at risk of hitting your head or of experiencing some type of head trauma and brain injury as a result. It's also more common, or it also can happen from accidents as well, right? Like you fall or car accidents or something of that nature. So when you're talking about what causes Alzheimer's, so Alzheimer's actually is the most common neurodegenerative disorder, and it's marked by significant cognitive impairment. So these people might demonstrate memory challenges, processing problems. They might struggle with problem solving and speed of processing. They're really sometimes they might even demonstrate personality deficits and challenges, impulse control, irritability, that type of thing. Now, with Alzheimer's, in order to be diagnosed with Alzheimer's, you either have to have genetic testing that shows that you do in fact have the gene and the marker for Alzheimer's. Now, just because you have the gene, the marker, doesn't mean you're going to have Alzheimer's. But if you have Alzheimer's, you should also have the gene. Or there can be a documented family history. So in my case, I do have a grandmother who was diagnosed with Alzheimer's, and in her final days, she really she needed to be institutionalized, and she no longer really had memory or recollection of any of the family members She wasn't capable of caring for herself. The one thing that her memory held on to was actually her scriptures and her songs. So she loved praise music, and she could still sing a song, and she could remember all the words to some of her favorite hymns and worship songs. And so it was really sweet to see the comfort that it brought her to sing songs or hear hymns, and the joy that washed over her face. I actually went to a talk, and I heard a community group, and I don't recall their name. I always worry when I don't remember things if I have early onset Alzheimer's. Just my fear, which is why I will not get the genetic testing, because self-fulfilling prophecy is real, and I don't want the gene, because then I might start manifesting symptoms earlier than I would otherwise. So I'm doing my best to be a lifelong learner, which can be a protective factor. Okay, back from that tangent. There's this wonderful program in Hawaii, and this woman actually links individuals who are suffering cognitive decline and in nursing homes with music from their generation, from their era. And so she gives them it used to be an iPod that she would give them that would be mapped with music, but now it's another form of a playlist. Often they'll use like actual thumb drives that they put it on, and they give them the headset, and it allows them to hear music. It seems like our memory and emotional connection to memory or to music seems to reside in different areas of the brain that don't seem to be as detrimentally impacted by these neurocognitive challenges and Alzheimer's. And it actually brings them joy while they're listening to music. It actually helps them become more cooperative. So caretakers actually report it benefiting their lives as well if they have music time, and it's playing music from their era associated with their cohort and year of birth, and it's a beautiful, beautiful thing. In terms of the causes, so we call it plaques and tangles, right? There are these amyloid plaques and these neurofibrillary tangles that almost looks like, the brain gets like a coating over it. And the plaques are effectively build up a residue, a waste product that's not being properly cleaned out. So we all get plaques in our brain, just like in our teeth and in our ears, right? We get plaques, and even in our throat sometimes, right? We get plaques in our brain. And so we have systems that will actually go in and clean out those waste products throughout our body. That's what our urine is. It's cleaning out waste products from our blood system, right? So our body naturally, through cellular regeneration and then of course degeneration, we are naturally going to have some byproducts, some waste that comes through that. And in the brain, with Alzheimer's, those plaques and tangles are not cleared away. And so an accumulation builds up, and it's thought to now have a direct impact on our cognitive functioning. Now, I want you to know that we don't know direct causes, right? We know that these physical characteristics are evident in people with Alzheimer's. The cause of it is still unknown. We know it's related to genetics, but we don't know that genetics cause it, because some people with the gene don't actually manifest Alzheimer's. So know that as neuroscience and biopsychology progress, which is the fastest growing science, the study of the brain is just brilliant. So know that in 10 years, they may actually find that it's not the plaques and the tingles that are the cause. Maybe that's a symptom, and they'll have identified other causes. So stay tuned. If this is something that interests you, or maybe you want to go on and be a future neuroscientist and researcher in this area, then, continue to push that information out and keep us updated. But definitely, if you're staying in the field of psychology, it'll be, or any behavioral health related field, it'll be really cool to watch the research on Alzheimer's and see what changes. That being said, the areas, the brain structures most impacted are the hippocampus, the amygdala, the cortex, and then specific areas within the cortex as well. So here we go in terms of the specific areas within the cortex. We have the neurons shrinking and dying in the hypothalamus, the thalamus, and the locus cerebralis. And then also this other APOE gene, and this is a protein that actually helps contribute to that breakdown of the byproduct. And it's thought that people that have Alzheimer's may have a disruption to this particular protein. And then additional things that might impact it are toxins, specifically zinc and lead. And while in American society, we've done our best to kind of remove, lead out of like paints and things like that, it's still the older individuals may have been exposed to higher concentrations than what we see like in current building structures. And zinc is also associated with Alzheimer's. Now, most of the time, Alzheimer's impacts people over the age of 60, but there is early onset where you start manifesting symptoms before 65. And typically, if you have early onset, there's some genetic risk factor in family history, such as myself. And later onset, it can be any combination of the biological, environmental, or even lifestyle factors. Sedentary lifestyles are associated with Alzheimer's. High-fat diets, high-sugar diets, low exercise levels. So things that you can do to reduce your risk is be active, live a healthy, full, productive life. Make sure you're maintaining ongoing physical engagement, social engagement, and cognitive engagement. I'm a TV junkie, so that doesn't help me. If you can commit to lifelong learning, to puzzles, to all those types of things, that's all very helpful. So let's talk a little bit about traumatic brain injury. So when you're talking about traumatic brain injury, now this has to have some sort of outside injury that causes some sort of head trauma and damage to the brain, ultimately, to the head and the brain. And they will start to show some cognitive deficits almost immediately after the head injury. Often it can coincide with a loss of consciousness, amnesia, or a loss of memory or dysfunction or disruption to that memory. It doesn't have to be permanent. They can be disoriented, confused, and their reflexes can be tested by a neurologist, and they may be impaired as well. Symptoms that the patient might complain about is a headache, often excruciating, lingering, chronic headache. Again, the disorientation and confusion. They might also have a personality change, and you might see them become irritable, easily provoked, look for tiredness and fatigue, inability to focus and concentrate, and then that behavioral and emotional change, outbursts, anger, hostility, those types of things might be manifested. You might also see something like a seizure. Anytime you have a seizure after a head injury, it's really important to go to the ER. Any kind of paralysis, whether it's facial paralysis or throughout the body, and any kind of visual disturbances, all of those things indicate a need for immediate attention. And then in terms of comorbidity, we often see people that have suffered traumatic brain injury. They may then also have coinciding depression, anxiety, and even suicidal ideations. So it's important that they're monitored and that they're supported as they're recovering, right? The most common form of TBI is a concussion. Recurring concussions are a big fat red flag for other challenges because they can in fact cause permanent damage, and we need to be mindful of that, particularly for the athletes in our family. Chronic traumatic encephalopathy is a progressive degenerative disease that results from repeated head injury, repeated trauma to the brain. And that might be from playing sports like football, where there's that high impact and high contact sports, particularly head to head. That's why they've done their very best to try to implement significant penalties and policies against certain hits where you can hit someone. You can't go helmet to helmet. They also have instituted the medical exam to make sure that they pass concussion protocols after they've suffered a significant hit. This also, we don't recognize it, but it also can be something that we see in soccer players, in wrestlers, in boxers. So those are the sports where you have to really, really pay attention for this chronic repeated head injuries. Again, like TBI, it can also be coupled with depression and impulsivity challenges as well. Sadly, what happens is long term, these individuals often show dementia symptoms and often at earlier ages as well. Notice I'm saying dementia, not Alzheimer's, because TBI is an environmental factor, and remember, Alzheimer's does have a genetic and biological component. Oh, sorry. Other disorders to consider are vascular disorders. So our vascular system is our blood system, our veins, our arteries that run throughout our body. And sometimes you have vascular challenge that disrupt blood flow and oxygen flow to the brain, which then of course can cause cognitive deficits and neural deficits. So you can have a one-time event such as a stroke, which can either be hemorrhagic, where your blood vessel bursts, or ischemic, where there's a clot that is blocking the blood flow in that vessel, and consequently your brain is not getting the blood and oxygen needed to function. Now, there is medication that they can give you to dissolve that clot and minimize the symptoms or the consequences of the stroke if they intervene within that appropriate window of time. So immediately when you start to experience stroke symptoms like droopiness or paralysis on one side of the body, often people with stroke complain of an excruciating headache. They might have visual disruptions. They might have attention disruptions. Sometimes they might collapse. And so it's important to get medical attention right away. Any kind of paralysis throughout the body or the face, slurred speech, where they might sound like all of a sudden they literally have lost their ability to move their mouths or tongue appropriately. Now, of course, stroke is also can be fatal, and so it's most definitely critical to get intervention, but it causes brain death, neural death, or damage at a minimum. Now, most people who have strokes are over the age of 65. Smoking increases the risk of stroke. Having a baby increases the risk of blood clots too, so that's something to think about. Flying in an airplane, those types, especially on a long trip where your body's not up and moving, that also puts you at risk of a clot that can then cause a stroke. So other symptoms might be some behavioral or emotional changes as well. And so definitely, depending upon what area of the brain is being impacted, that is going to, whatever associated functions are associated with that brain region are likely going to be impaired as a result of the stroke. So substance abuse can also cause neurocognitive challenges, and people don't always realize that. When you're using drugs, they can cause effectively permanent brain damage. Sometimes when you're actually high or drunk to such a degree, it can cause delirium. It might pass, but if you're a frequent repetitive drug user, that actually may result in persistent neurocognitive challenges. So it's really, really important to recognize the long-term implications of substance abuse. And because addiction can be so prevalent and powerful, we want to try to intervene in people's lives as early as possible to prevent long-term damage. Then there's also dementia with Lewy bodies. Again, you're going to see distinct brain structural issues, including irregular brain cells from a buildup of other proteins in the nuclei. And so you're going to see definite symptoms in the cortex. Now, here's the sad thing. We may not be able to see these things until an autopsy, right? So certainly understanding someone who has dementia, understanding the implications and maybe donating their brain and their body to science can aid in our knowledge of these disorders, can help to educate our future medical doctors and practitioners, and can potentially maybe help us find a cause sometime down the road. Same thing in terms of attention, alertness. They might actually experience hallucinations, sleep disturbances. And typically when you are diagnosed, it's about an 8-year life expectancy, which can be challenges. So they can look at dopamine, acetylcholine, and they also see significant motor functioning and impairments along with the cognitive decline. And so this diagnosis, all of them are excruciating. They're all heart-wrenching. So cherish your loved ones, right? Cherish your loved ones. Build those memories, support them in any way you can. Parkinson's is another neurocognitive disorder. This is a neurological disease. They primarily experience degeneration of neurons within the frontal and temporal lobes, which obviously is going to impact their language because the temporal lobes and frontal lobes are critical in our language production and processing, and every other function associated with those brain regions. We often see behavioral changes. They might actually start to express different types of emotional engagement. They might show a little bit of apathy and maybe impulse control. They don't inhibit their reactions in the same way or behaviors in the same way they would otherwise. They may withdraw socially and emotionally. and their inability to connect to others, and their executive functioning associated with that frontal lobe also starts to decline. So you're going to see some marked symptoms in how they communicate, the fluency by which they speak, is their tone, their rate of speech, their pausing, all of that will vary. And they'll lose the ability to just name objects. So their crystallized intelligence, or at least access retrieval for that information, declines. And you might also see muscle weakness and physical abnormalities in the way that they walk, in the way that they move, in their posture and stature. So, and again, dopamine is associated with that as well. And then frontotemporal lobar degeneration is another neurodegenerative disease, the second most common, in fact. It might cause tremors, rigidity in the limbs and trunk. Their movement is slowed, and they might have a very droopy posture. Balance and coordination is impaired. And they typically have about 1 year physical symptoms before they start to manifest those cognitive impairments. Huntington's disease, which is a genetic disorder you may have learned about in a developmental psych class, they also have motor impairments, including involuntary movements. That also comes with a degenerative dementia and some emotional challenges as well, right? When our brain is degenerating, our emotional regulation is degenerating as well. Our personalities are changing. So sometimes we can grow impatient with these individuals, but recognize that it's not them. Don't take things personally, and wrap them in love and patience as best as you can. Tag teaming is really important. Again, their life expectancy is about 15 to 20 years. People actually report, pretty significant impairments. They become fully dependent in the latter part of their life. And it can be a very excruciating way to go for both the patient as well as their caretakers. Most people don't realize that HIV can actually cause dementia, particularly if it's left untreated. It's actually one of the first symptoms to emerge for HIV, but they don't process information as quickly. They may not be able to engage in the same types of complex tasks that they did at one time, difficulty concentrating, and they struggle with learning. And so there is inflammation, right? Because it's negatively impacting your immune system, and inflammation is an autoimmune response. And that happens throughout the central nervous system that impairs their cognitive functioning. Now, the antiretrovirals that they take to treat HIV can actually help stay these cognitive impairments, but if they're not getting treatment, then they're not benefiting from those antiretrovirals. But I highly recommend antiretrovirals. The medications really have great success rates now. We've come such a long way, and we can reduce the HIV in your bloodstream to undetectable levels now. So overall, treatment for all of these disorders is often a pharmacological, right? There's medications. Each disease has different medications. They're not treating the disease per se, they're treating the symptoms. The medications can often slow the progression of the disease, but they cannot cure the disease. Except for the antiretrovirals. They do reduce the presence of HIV in the bloodstream. And then psychological treatments, again, keep your brain cognitively engaged and active. That social engagement, social skills, continue to practice that. And you can actually continue to train life skills and self-care skills so that people can maintain their activities of daily living. They need help, but you want them to be as independent as possible. So if you are a caretaker for one of these, for someone with one of these disorders, it's really important to let them do as much as they're capable for themselves. Challenge them, encourage them, wrap them in love. Don't be pushy, don't be critical, but instead invite them for that independence, and they will benefit from that. It will help to kind of slow the progression of the disease. Break things down, keep it basic and simple for them. Simplify the environment as best as possible to make life easy for them, but still give them stimulation and challenges. And then make sure you're not just supporting your loved one, but you're supporting yourself. As a caregiver, you are at greater risk of depression and suicide. It is a very taxing and draining job, emotionally and physically. So make sure you're getting the care you need before it impacts your relationships, before it impacts your own emotional health and your own social functioning, right? Make sure you're getting involved with support groups, that you're building a network that can come in and offer respite care, and you can tag team where you're doing every other day, or you're doing mornings and someone else is doing evenings. And then make sure you're seeing a therapist and getting as much help as is available to you. And I want to leave you with some words of support and encouragement for this particular set of disorders. First, brain injuries are like snowflakes. Not one person's the same, right? Know that we're talking about a range of symptoms, and your loved one is an individual, so their symptoms might vary. Make sure you're working actively with their healthcare providers and getting them the individual support and care they need. Secondly, these survivors of brain injuries and these individuals coping with neurocognitive disorders, they are still with us. Sometimes we treat them like they're invisible, and worse yet, we treat them like they're burdens. So have patience with them. Recognize them as intelligent, wonderful human beings. Sentient human beings, right? With emotions, needs, human needs, urges, and try to give them as much empowerment as possible. I saw a TikTok, and this lady was recording her mother who had dementia, who was wandering off. She approached her mom. She said, "Hey, Mom, where are you going?" Her mom's like, "Hey, I'm going to walk to New York," which was in a few other states away. And her mom says, "Well, gosh, what's in New York?" The daughter says, "Gosh, what's in New York?" And she says, "I think it'll be fun. I just want to see New York. I haven't seen New York. I'm going to go to New York." And her daughter says, "Gosh, Mom, that really does sound like fun. Do you mind if I come along?" And her mom says, "Well, sure." And she said, "Okay, Mom, but I need to pack some stuff because I hear it's really cold in New York. So how about we go inside? Would you mind if we go inside and you wait for me to pack some stuff for us?" And her mom's like, "Sure, no problem." And then she says, "Mom, can you help me pack?" And she says, "Yeah, let's go." And Mom goes back inside. And that was a beautiful, loving way to guide her back inside. Now, it's quite plausible that in a few minutes she'll forget about her adventure to New York. But in that moment, instead of creating hostility, defensiveness, resistance, you gave her self-determination. You gave her empowerment. You gave her independent choice. You gave her dignity. That is a beautiful lesson for all of us to learn when we have loved ones that are suffering from these cognitive declines. For all of you who are caring for someone or have lost someone to these diseases, I send you much love and aloha. Take care of you just as wholeheartedly as you take care of them. Bye-bye.